Dr. Kenneth M. Rogers. He was born and raised in Dillon, South Carolina. He's a graduate of the University of South Carolina School of Medicine. He completed both his general psychiatry residency and a child and adolescent psychiatry fellowship at the William S. Hall Psychiatric Institute at the University of South Carolina. He's board certified in both general psychiatry and child and adolescent psychiatry. He also holds a Master of Science in Public Health from the UCLA and a master's in medical management from the University of Southern California. Prior to returning to South Carolina, Dr. Rogers served as chief of psychiatry at Parkland Health and Hospital Corporation and professor of psychiatry at the University of Texas Southwestern Medical Center in Dallas. He has a long history of working to expand mental health services to underserved populations by partnering with both traditional and non-traditional locations of services, including faith-based communities, schools, and correctional facilities. He has presented and published wide in the areas of child psychiatry, juvenile justice issues, spirituality, cultural issues, and healthcare system reform. These are all things that we have talked about this week, and we're so excited to have his expertise as the state director of the South Carolina Department of Mental Health. So, without further ado, everyone, please continue to engage in the chat box. You have an expert here, a doctor who works with children specifically and talking about children and pediatric psychiatry, but he's going to talk a bit now about mental health, poverty, COVID, all of those social determinants of health and how they work together. Without further ado, I will give it over to Dr. Kenneth Rogers. Dr. Rogers.
Thanks, Nafi. I appreciate it. Good morning, everyone. It's so great to be here with you this morning. I'm still getting used to this virtual thing, even though we're a year and a half into it. I'm still trying to wrap my head around actually talking to folks that I can't see. This like throws me off totally. But again, I am happy to be here with you today. So I've got a number of slides that I'm going to go through. There's some things I'm going to talk about. But I find that it's really most beneficial for me and perhaps most beneficial for you if things come up, if there are questions that come up, things you agree with, disagree with, things you'd like more clarification on, please add it to the chat box. Would love to kind of engage. I hate kind of single direction interaction. I do much better with dialogue and some talking back and forth with things. So please feel free to interrupt, share, and let's make it more of a conversational thing rather than me just kind of talking to you and at you today, because I think that for me, that would be really most helpful and most beneficial. So today what I'm going to do is spend some time talking about mental health. Going to talk a little bit about poverty and then a little bit about COVID-19. In the context of a lot of this, I'm going to make it somewhat South Carolina specific. I know you guys are in North Carolina. The systems are a little bit different, but I think that it will give us a context for kind of putting some of this stuff into a perspective that may make it understandable and helpful. So today's task. So we're going to talk a little bit about why I'm here. I'm going to define the whole idea of mental health and how we define mental health. And I primarily do that because I think that it means different things to different people. And so I think having a context for us to have kind of an agreement of what we're talking about is important. We're going to talk a little bit about trauma. I'm going to spend some time talking about the structure of mental health in South Carolina because I think it's unique, but also I'm going to talk a little bit about North Carolina because having lived on the border most of my life, I have a little bit of understanding of North Carolina's system as well. We're going to talk a fair amount about COVID-19 and some of the societal impacts there. And then we're going to talk about a couple of case studies and some discussion that we're going to have back and forth. So why am I here? Originally, I did this talk in Myrtle Beach, but I left this slide in here because I want to talk a little bit about why I'm here with you today. So North Carolina, I grew up about 7 miles from the North Carolina border in Dillon, South Carolina. So for those who've gone up and down I-95, You've seen those tacky Pedro signs at south of the border, welcome to home. So I could go up in Pedro's hat and I can see my house from there. But it also has afforded me the opportunity to really spend some time kind of engaged and interacting with you around some of the opportunity that life begins to create for each of us. I feel very grateful the opportunities I've been afforded and would like to be able to share those things with others. So this is where I grew up. And I throw this in here because it helps put my thinking into a perspective. So Dillon, South Carolina is a very small city, about 8,000 people in the entire city. If you look at the crime statistics, it receives an F grade, which means that 94% of cities in the United States, both large and small, are safer than Dillon, South Carolina. The makeup is about 52% Black, about 44% white. It's number one in the state of South Carolina in terms of disproportionate minority confinement, and it's the second worst school district in the state of South Carolina. So if you put all those things together, what does that mean for mental health in Dillon? So why am I here? I am intrigued by the idea of poverty. And as I've gone further along in my career, I've become increasingly more intrigued by the concept, largely because I look at my own childhood and I look at where I am now, I look at those with whom I work, and it gets into this really interesting thing of what does poverty do to you? How do you define it? How do you perceive it? And how does one get to the place where they become unpoor? Is it just having, additional money? Is it having other things? How do we change the perspective of others? And so I think that what your group does is so incredibly important in not just moving families to a different place, but actually helping to change the dynamic of their lives and the trajectory of where they are going long term, which I think is incredibly important in what we do in terms of moving people forward. And then there's this idea of systems. So part of the reason why I chose child psychiatry is, one, I like working with kids, but also if one can understand systems and how systems work and really understand kind of the flow of those systems, you can get to a place where you're able to make change because of the systems work that you can do. And then it's also the empowerment of others. So how can I use my story, my life, my position to begin moving things forward? Having trouble advancing my slides here, so I apologize. All right, so when we look at poverty and resilience, how do you define resilience, or how does it define you? So as I think about, my own life, and I'll just kind of give you a quick background. So I'm the kid that grew up in a relatively impoverished background. My father was a factory worker. My mom was actually worked at a nursing home as a cook. She got injured when I was a kid in an accident, and so my dad's income was primarily what supported us. I was a kid that got free lunch in school. I was the kid that basically had all the social programs and engagement around. And what was interesting is after a few years, as my mom continued to recover, she actually helped to start the first Head Start program in Dillon County, which is where I first became really involved with kind of the idea of social networks and really the underpinnings of how those help in our society. So when we think about poverty and resilience, I think that it really gives us a chance to think about how do we move children from this place where they are relatively at risk to a place that's actually very, very different. And then it gets into the idea of really helping to change how one perceives oneself and then how others perceive you. So part of the work that I think that you do, which is incredibly important, is helping with self-identity. And so I think about in my journey, I never realized I was poor until I hit college. When I hit college, it was a very interesting experience because suddenly I realized that there were others in my social network who had a lot more stuff than I did. But I had also been shielded by a group of people, whether it was church, whether it was a community that was very supportive, even though it was poor, that actually never allowed me to perceive myself as something different than or lesser than. And so how do we help kids get to that point, which is what I hope that we will spend some time talking about today, the idea of becoming unpoor. So frequently what we describe as poverty is really less about not having money and more about how do we have a system of things in place that actually limits the opportunity for individuals, whether that's a lack of job opportunity, whether it's impoverished schools, which don't work as well, which limit future trajectories, or whether it's mental health issues within families. There are a lot of things there that keep us what I'm going to describe as poor. How do we think about those transferable skills? What are the skills that we can develop to move people forward? So one of the things that I've worked on with families is, especially with mental health issues, is how do we help a child see themselves as different than they are now? So let me explain what I mean. When you have a, let's say, 6 or 7-year-old walking in the office, a 6 or 7-year-old is at the point where they're trying to figure out, who am I? What's kind of my life? And that's largely defined by the individuals around them. It's going to be defined by the teacher who's actually coming in and talking to them. It's going to be defined by the other social networks that are around them and what's happening there. But it's not going to necessarily be what's intrinsic to the kid. And so part of what we tend to largely work on is how can we work with those systems that are around the child to begin to move that child and that family in a positive direction. The second thing is really beginning to look at, the idea of mental wellness. So we've talked a lot in our society about mental health issues, but when we think about mental health, mental illness, and mental wellness, I think it's really important to look at how do we not necessarily look at the absence of depression, the absence of anxiety, the absence of psychosis, but really how do we look at helping children and families get to a place where it's about wellness, where they're engaged, where they're feeling fully alive with the environment that's going on around them. And then lastly, it's about empowerment. How do we move from helping individuals feel like they're victims into a place where they're really taking control of their lives? One of the things that I've talked a lot about groups with, especially professionals, is the idea of what's the role of mothers, for example. And one of the things that led me into this conversation was recently I was having a discussion with someone in my office who was talking about a mother who they felt like was kind of overly engaged, who seemed angry in some ways, who they described as feeling like they that she was doing more and more than she had to. And that was actually frustrating people more and more. And so then we got into a discussion of what has been that mother's impact on you as a professional. And at the end of the conversation, what we realized is that because of mother's pushing, her level of what they perceived as being anger and control, that there was a realization that she had actually gotten the therapist who I was in this relationship with to do more than she would have otherwise. And so helping folks to figure out, how do I begin to perceive behaviors of the folks that I'm working with in a very different way than I would have otherwise. So as we think about mental health versus mental wellness, if we look at DSM-5, which seems to be the Bible of everything that we do related to mental health, it defines what a mental illness is. DSM-5 says if you have depression, you have 5 of 9 symptoms. This is what we're going to call it. However, that really is different than kind of thinking about mental wellness and mental wellness overall. As we're thinking about the idea of trauma, if we look at our society, especially in the time period in which we live, there are a number of traumatizing things that I think go on, especially when we look at the lives of relatively young children. We think about the social unrest that's happening in our society. We look at the social isolation, which is occurring. I was recently looking at the crime statistics for referrals for criminal domestic violence, which have substantially dropped in the state of South Carolina. But what I think is most concerning is we really don't have an idea of the level of trauma that's actually occurring among our young people, not only in South Carolina, but in the country at large, primarily because those kids aren't coming into contact with other adults. So for example, if we look at the number of children not attending school, we have had them out for a long period of time. If we look at the fact that teachers are often the number one people who are picking up on the trauma that's occurring, it becomes extremely important. And so the level of trauma that exists out there, both physically, sexually, and emotionally, I think has substantially risen. Now, what makes me think this? On the other side of what we know is that we know that substance use has actually risen substantially during the pandemic. If we look at marijuana use, we look at alcohol and other drug use, the numbers are actually substantial. We know that adults using drugs and being at home all the time with young kids, again, that can sometimes be very stressful. We know that those numbers are rising, but we have not found a way of capturing it. And so I think that from a post-pandemic, late pandemic look at things, we're going to continue to see a number of events that will remain problematic. Then stress reactions versus mental illness. So we talked about the stress that's actually happening in society in general. Those stress reactions may be different than what we define as mental illnesses, or they may actually be the same. For example, if you get a 6-year-old that comes in the office that's hyperactive and not sleeping, how do you look at what that is? In the past, we would have probably gone immediately to, is this depression? Is this ADHD? Is there a mental illness there? However, we know that the other thing that can occur is what we kind of think of as a normal stress reaction in kids. And so if you take the average adult, you decrease their sleep, you add in enough life stressors at work or financial stressors, the other stressors at home, we know that one begins to see a reaction to that, which in mental health we refer to as an adjustment disorder. And so I think what we're beginning to see is really more stress reactive behavior in children than we have in the past because the level of stresses have increased. The other thing that I think is important from a trauma standpoint is to look at what or how we define trauma in mental health. So we look at type 1 versus type 2 traumas. So type 1 traumas are those single event kinds of things. I'm at home and a gun goes off and I see someone killed in front of me. That's a type 1 trauma. It's a single event. It's usually relatively recent. It's there and then it's gone away. The type 2 traumas are the repeated traumas that are occurring. The child that's bullied in school incessantly for 2 or 3 years. The person that's physically or sexually abused at home over the course of months to years. Now, if we think about the impact of those traumas, which is going to be most problematic? Is it going to be the type 1 trauma, this the single event that's occurring, or will it be the type 2 trauma, the repeated, continued event? Now, we all know if we think about it, that the type 2 traumas are going to be the ones that are going to be most problematic. However, if you look at the lives of kids, it's generally type 2 traumas that we see playing out over and over and over again. And so it's these repeated traumas that are those adverse events that we end up talking about quite a bit that end up having an impact, not just on mental health, but on mental wellness. Case in point is yesterday, I was actually seeing a lady who happened to be 50 years old. And we were in a conversation about why she was having difficulty with relationships. She's in the process of likely going into her second divorce. She's having difficulty engaging with her adult children. She is college educated with a master's degree, but continues to struggle with difficulty at jobs. As we began to kind of unpack and dissect some of the things that were going on in her life, what we realized is that it was a group of childhood traumas that really went on from about 8 to about 18 or 19 that have really totally shaped her life. She's never been in mental health treatment before. She's always been extremely anxious. She doesn't sleep well at night because she doesn't like the dark. So those repeated, frequent traumas that have happened over the course of many years, and in this case, 30 years ago was the last time that any of it happened, continue to have a significant impact, not only on her relationship with her spouse, her relationships with her children, her relationships with her friends, her ability to do her job, and the fact that she now has become increasingly more isolated is really a result of those type 2 traumas. We also get into the family and intergenerational issues. So as we think about the idea of trauma, as we think about the idea of depression, one of the things that we have a lot of information on is the fact that we now have really, I think, overwhelming evidence that shows that a history of depression in a mother, for example, is one of the most powerful impacts for negative outcomes for young people. And so how do we begin to think about addressing some of those intergenerational issues as part of the work that we do with children, their families, but also helping mental health and other professionals really look at the fact that this mother may not be able to fully engage in a way that we would expect when she's walking into the room. The fact that the father may not be engaged in a way that we see as appropriate. The fact they're showing up may actually give us an opportunity to help reshape the narrative that this family will have in the next generation. And then finally, the thing that I'll talk about is the idea of vicarious trauma. That trauma has gone on for a lot of people for a number of years. And part of that vicarious trauma, especially in the mental health world, is really related to hearing the story over and over again of a lot of the difficulties that have occurred within the family and within the office. One of the examples that I frequently share with people is when I was a trainee, a resident, in my second, third year of training, you end up with all psychotherapy. And that's what I did day in and day out. Before I really realized what I was doing, I would come home depressed every Thursday. And so I'd actually gotten married at that point, and my wife was the person that actually pointed out, you know, you're actually happy every other day of the week except for Thursdays. And at first I thought she was a little crazy, but then I started looking at it, and she was right. I was really depressed every Thursday. And so as the conversation continued, what I realized is that I had actually, on Thursdays, put in 3 hours of depressed patients, 2 hours of patients with PTSD, and then a number of other educational things that were there. And so I literally created this situation where I was going through vicarious traumas related to that particular day and not having the experience and the skill set to really be able to know what to do with it. It's made me realize as I've gone through my career that happens with a lot of folks that are working with children and families who have gone through difficult situations, in that they end up experiencing that trauma as a secondary effect, and can often have the same effects, although at a much lower level, than sometimes the effect that we would have on the child and the family themselves. So I thought I would give you a quick overview of the State Department of Mental Health in South Carolina as part of our transition. So South Carolina is a really unique state in that we are now at our 200th anniversary this year. So it says 1828 on the screen here. But we count our history going back to the organization of the state hospital, which was enacted into law in 1820 and 1821. That system over the years has created a group of mental health centers that are spread throughout the state. South Carolina has 46 counties, and so we have centers in 44 of those 46 counties. We have 3 hospitals, which again are spread throughout the state. We're also responsible for state nursing homes, sexually violent predators programs, etc. We have about 100,000 patient visits per year, but we also have other contacts with folks throughout the system, which we don't count as patient contacts. There's some of the work that we do in communities where we don't open charts. There are works that we do in jails and other settings that we don't count as visits. And so there's about 150,000 visits per year. Over time, we have treated over 4 million patients. We have a budget of about $500 million per year. We have a number of places that one can engage with us, again, whether they're hospitals or nursing homes across the state. There's satellite clinics, again, in all the counties throughout the state, or at least 44 of the 46. And for the 2 counties that we don't have offices in, we actually have mobile treatment centers, which actually go to those counties and park in local Walmart parking lots, church parking lots, etc. We talked a little bit about our assessment and evaluation centers, whether it's working with juvenile justice, adult forensic populations, sexually violent treatment, predator programs, etc. We work with a number of local hospitals, and so we have folks stationed in a lot of our emergency departments throughout the state, which allow us to do both video visits as well as sometimes having folks on site there as well. We're in about 70% of the schools in the state of South Carolina with having an on-site school mental health clinician that's actually in part employed by the Department of Mental Health that's working in that local school. The school programs we've found to be extremely beneficial because, again, it's about identifying issues, trying to get to them as early as possible so that we prevent a lot of the negative outcomes that we would see long term. Overall, there are about 1,000 portals of entry across the state when one looks at all the programs that I just described. Crisis services is something that we, I think, have done very well. It's similar to a lot of the crisis programs in North Carolina. Some of the challenges that we have seen over time is the increase in deinstitutionalization, which of course has led to a rise in homelessness and not being able to keep up with the level of mental health illnesses that are there. One of the biggest challenges with deinstitutionalization is if you look at the state of South Carolina, within the course of about probably 5 years, we decreased our number of beds from about 10,000 down to almost zero. And down to zero, meaning about 400 beds. And so there was a substantial decrease. What that meant is that there are a lot of people who didn't have places to live. So it increased poverty, it increased unemployment and homelessness, which of course we know are some of the social determinants of health. So the other thing that we have worked with is working locally with our police departments. And so we have a number of folks that are actually in ride-alongs with police officers, again, trying to help folks learn how to engage with people with mental health challenges. We're now in about 12 police departments across the state of South Carolina. And then, of course, there are the current political climates related to policing. Part of what we have tried to commit to doing in South Carolina is around the idea of community policing. We have tried to prevent, to the extent possible, some of the issues that we've seen in other areas across the country. So if one looks at the history of policing, it really largely grew out of, in the early 20th century, really looking at a much more punitive model, especially in many minority communities. And so helping to figure out how can we as a mental health agency, one, begin to work with some of the social issues that are there, but also helping police understand the challenges that may exist across mental health issues, across racial issues. And what's been, I think, really heartening for me is the partnership that we have been able to engage in, especially with some of our larger police systems in the state, who are really committed to doing very positive things in the community. And I'm very, very proud of the work that we have done there. Big problem for, of course, mental health is frequently the lack of funding. As we have looked over time, we have seen mental health budgets cut substantially. But of course, now in the pandemic, what's become increasingly interesting is our budgets have actually risen, but our ability to hire staff has actually dropped. And so part of the fear that I have, especially as an agency leader, is will we be able to meet the demand? Will we be able to keep those 750 school-based programs open? Largely because we're not able to find enough master's level clinicians, social workers, licensed professional counselors to work in those programs and provide the services. And so we have more recently struggled with how do we look at our model of providing care? Are we able to do it in a different way than we have in the past? And is there a way of looking at quality controls as we begin to think about those different models? The great resignation, I think, has become, the term that we see and hear a lot. But for us, it really has hit us. And so we have about 400 open positions for master's level counselors across our system. And as we begin to see a lot of the need that I described earlier, we're not able to get those people in. And so we're really at this dire point, and North Carolina is experiencing the same thing of, will we be able to really address the issues that are happening at a time when those needs are beginning to skyrocket? And so again, looking at what those models are and thinking very differently about what we can do with them. Emergency department visits have substantially, again, changed with COVID. One of the things that we saw at the initial onset of COVID, if we go back to beginning of 2020, is we saw actually a drop in volume in emergency departments as people became afraid to actually show up for visits. But as we have gone further into COVID, and we're seeing an increased level of stress, what we're beginning to see now is a rise in the number of folks seeking mental health care each and every day. Those disparities are becoming increasingly more noticeable in rural areas, but also in largely urban areas where we're not able to, again, hire people for some of those local clinics, for some of our emergency rooms that are providing some of our emergency and crisis services across the country. Now, when we think about crisis services, we're looking at really three things: 24-hour crisis lines. So is there a place that someone can call and I'm suicidal? Can someone talk to me, tell me where to get services, talk me through the initial problem? There's walk-in crisis services. So whether it's an urgent care center, whether it's an emergency room that has a mental health component associated with it, is there a place I can walk in and talk to a counselor? And then finally, thinking about mobile crisis. Again, we have teams that work with law enforcement. We have teams that go out into the community to calls related to 911, et cetera. So beginning to look at how do we begin to engage in many different ways. So what's the goal of what we do? So in many cases, what we used to think it was about independence. Can we get to a place where we're helping people develop a way of becoming independent from families, independent from other people, doing more and more and more by themselves? With kids, that becomes increasingly problematic, but also problematic with adults, because sometimes independence is not necessarily what we want to look at. But we also don't want dependence either. How do we become so dependent on others that we aren't able to develop the skills that we need to stand on our own? In kids, of course, dependence is going to be something that's going to be key. But ultimately, what we want to do is move to what we think of as interdependence. So for those of you who are kind of from the same era, same age I am, of course, these are the Waltons. I used to love the Waltons because I think that the Waltons model is really an idea of society and what society should look like. Can we get to a place where there's an interdependence upon each other? And so one of the things that I have committed to in my work with families and my work with communities is not necessarily to look at the idea of dependence or even interdependence or independence, but how do we create appropriate interdependence between what we kind of think of as natural helper situations? So if I think about, again, childhood and what we were talking about earlier, growing up in a small town, it was very poor. The school district was not the greatest one, again, the second worst in the state. But what there was there was a community that was interdependent and supportive of each other. And so literally I could walk anywhere within probably an 8 to 12 block radius of my house. And I knew everyone around me, and people knew me. They knew my family. They knew that I was a part of the community. And so people began to take care of me. I think about when I actually went off to college, one of the most touching things that I still think about was there was a group of elderly women that actually took up a donation to help me in college. And it was an envelope that they came and gave me, and it had about $150 in it. And until this day, I still think about the meaning that that $150 had on me and the impact it has on me now. It really said to me, Ken, as a community, we value where you're going, what you're doing, and we want you to know that we're proud of you. And so how do we recreate something that's similar to that in this day and age, where we're in much larger situations? We tend to be more polarized, and the things that we would normally do may not be available. How can we again think about developing that interdependence and helping kids feel like they're part of a larger community? Now, as we think about community systems, we see that children are really part of really a large set of systems, whether it's families, schools, social welfare, social service agencies, juvenile justice. There are a lot of places that kids end up plugging in. And so how do we help develop and create those systems that can again be very, very responsive to others? So I'm now going to look at a couple of cases. If we were together, we would be able to kind of talk through some of these things a little bit more, but I'll try to do something similar while we're on the screen as well. So case one, Mary is a 7-year-old girl who lives with her mother and father in substandard housing in a rural community. Her parents are both 17 years old at the time of her birth. Her mother completed high school, but father dropped out of school upon completion of the 11th grade. Mother has a history of depression that was first diagnosed at age 12. She has had several jobs, but has not been able to sustain employment for greater than a year. Father has been working as a mechanic at a local garage, but recently lost his job due to lack of business. The family has struggled with food insecurity as a result of the father's job loss. The child's teacher notices that she was hungry and notified the school social worker, who made a report to the local social service agency. So what are some of the challenges that we see with this particular case? So first of all, we think about Mary being a 7-year-old girl. So developmentally, we're 7-year-olds, and what do they need? We know that one of the things they're searching for is belonging, identity. We know that they're in school, and so they're at the point where they're just beginning to figure out how to learn, how to engage, figuring out where they are going in the future. We know that she's in substandard housing. We know that that puts her at risk for a lot of those ACEs that we talk about, those adverse childhood events. But we also know that it puts her at risk for difficulty with learning. Her parents, again, were teenagers when they gave birth to her. Mother completed high school, which is a positive. But father dropped out, which of course is going to limit his ability to provide in the future and puts him at risk for underemployment. We talked about earlier the idea of maternal depression and the impact that maternal depression has on especially daughters. So if we look at mother to daughter transmission, we look at father to son transmission, it's extremely strong. And so we know that Mary is at great risk for depression, or at least for mood-like symptoms. Father recently lost his job, again, increasing the level of stress in the family home. And of course, food insecurity is going to be a huge issue. The last paragraph, we look at the impact of social welfare and social services agencies and their ability to, again, work with this family. Social welfare agencies are a very interesting mix in that they often provide services, but they often also place families at risk for negative outcomes, depending on the worker they're working with. We know that social welfare agencies are understaffed, folks are overworked, and so trying to figure out how to help a family who's already at risk navigate through a system like this one. Other challenges. We look at the fact that the crisis, as it's identified, is relatively vague. Again, urban versus rural challenges. Rural challenges is frequently, how do I get from point A to point B? Often a lot of social isolation, especially if a vehicle's not available. Often the expense in getting to town if one doesn't have a vehicle. Of course, in urban areas, also frequent challenges. One may be density of population. We may see increased crime rates in urban areas, and also risk levels, both intrafamily and outside of the home. And then we look at the interface between 3 or 4 systems. So we looked at school, we looked at social welfare agencies, that are then going to be a number of competing priorities for this family. So how do we help this child kind of navigate across these systems? So let's look at the second case. We have Johnny, who's a 15-year-old male who was recently detained in a local juvenile justice facility for assault and battery. The incident occurred as the youth was walking home with his mother from the store. Several youth were making inappropriate comments to his mother, and he attacked one of the young men in the group. The youth's older brother, who was a member of a local gang, was shot and killed 1 year ago. The brother died in Johnny's arms. He did not receive care following the incident. He was seen at a local juvenile justice facility 6 months ago and diagnosed with major depressive disorder, PTSD, and cannabis use disorder. A school resource officer was called to break up the fight between Johnny and another youth. Now, this case is extremely interesting, again, for a number of reasons. We see, first of all, a community that's under stress and having a number of stressors that are occurring. So we see kids really taunting a youth and his mother. Most 15-year-old males are going to be fairly protective of mom, which then, of course, is going to trigger behavioral kind of things that are going to occur. This youth, again, is traumatized because he had a recent loss with his brother, but also he's suffering from a number of mental health challenges himself. And then, of course, there are the behavioral issues, which are likely a result of mental health challenges or those social life kind of stressors that we talked about earlier that is now beginning to play out with this particular kid. So the challenges in this particular case, the safety of others, because even though we may know why it's occurring, again, there are safety issues that are happening. He is attacking and hitting other youth. We know that 20% of youth have, a mental health disorder. Most of those mental health disorders are going to occur before the age of 14, and the vast majority are going to occur before age 24. And so if you look at the trajectory of mental health issues, they're going to declare themselves fairly early in life, so that we will know, which then leads to, of course, school dropout, juvenile justice, detainment, and of course, suicide risk. And then we get into issues of race and ethnicity. And so as we think about the public mental health system, and we think about systems in general, by and large, we see an overrepresentation of Black and brown kids. So those systems then actually place those kids at increased risk, because once you're in a system, it's really going to be about looking more at stereotypical behaviors versus individual behaviors. Not necessarily because the folks running those systems or the folks working in those systems think stereotypically, but when you have large groups of people, you're going to have to almost think stereotypically, because you don't have time to think about folks as individuals, which places them in extreme risk. Now, this particular case was actually a young man that I actually saw about 10 years ago, which was extremely concerning. The couple of things about this case, which I think will highlight some of the challenges with young people, is that I don't have in here, is that Johnny was actually an A student in school, was doing extremely well. He was actually is a great basketball player, who actually played AAU basketball, was really on the fast track to becoming probably a great college basketball star, as was his brother, who also was involved as well. His brother, who ended up joining the gang not because of bad behavior, but because he was trying to protect Johnny and felt like, if I join the gang, I'll be able to keep my brother out of harm's way, really put himself in a difficult situation where he was eventually shot by a rival gang. So we see a kid that's actually in a two-parent family. Johnny's dad was actually in the family and witnessed the shooting as well, who now is in a very difficult situation where we are now in juvenile justice in a court setting where he is now at greater risk. In this particular situation, I think the thing that became most striking for me was that Johnny never recognized his mental health issues. The system initially didn't recognize Johnny's mental health issues. Thankfully, a corrections officer became concerned, who was actually someone who was a psychology major in college, who was the person that ultimately referred him for mental health care, which gets to how do we think about some of those larger issues of making sure that people are trained. So in the last few minutes, what I'm going to do is talk just a little bit about the transformation of mental health care. We're in the process in this country where we're moving from the old rotary phone to thinking about the iPhone. We're in this transformation where we're having to think through a number of things. We think about the increasing presence of telehealth services. So is there a way of moving from someone being kind of forced to show up in an office at a particular point in time to be able to do things? While I think that's incredibly important, I think having the presence of telehealth services has allowed us to really engage people in a different way. I frequently find that being able to engage folks at home during breaks is often very beneficial, especially with older adolescents and young adults. The availability of child-trained providers on crisis lines. We have previously thought about crisis services as being adult services where someone was calling in. We're seeing more and more adolescents calling into crisis lines compared to what we have seen in the past. The idea of integrated or whole person care, so that we're now looking at really treating the whole person and not separating mental health care from medical care in general. So how do we begin to think about putting that entire thing together so that a kid with asthma or muscular dystrophy is now not separated from the fact that this kid is depressed with PTSD, looking at funding models for mental health crisis services. In the past, trying to think about crisis services, how do we pay for them, how do we look at them, has been difficult because of the way our funding mechanisms in society work. And then finally, looking at more standardized approaches to pediatric crisis services. Right now, it's kind of hit and miss, depending on where one actually is in the work they're doing. Now, I'm going to finish up by talking a little bit about COVID-19. COVID has really changed the way that we look at things. And just to put a little bit of it into perspective, as Nafia was talking earlier, I started my job April 2nd of 2020. Before I moved back to South Carolina, I was at a children's hospital and a university in Dallas, Texas. January 2020, we knew that there was this thing that we were starting to see that was viral illness happening in the United States. We hadn't yet defined it, understood it, knew what it was. We had some of our ER doctors, and I was the ER psychiatrist at the time, who started wearing masks everywhere in the hospital. They were actually talked to by hospital administration because they were saying, this is an overreaction and you are really scaring people and thinking that it's something more serious than it really is. We know that by April 2020, we had folks wearing personal protective equipment everywhere. And we knew a lot more about COVID-19 and the virus. And of course, we began to see this exponential increase in illness and death. So that tells you how quickly COVID-19 has kind of risen and how we have learned more. But as we have learned more and changed things, it has also become much more confusing to the general population who frequently respond, everything's changing, so maybe you don't know a whole lot, which has then ramped up a political response, which has then made it into a very, very different issue that we're continuing to see. So as we look at that as a backdrop, what we continue to see is that COVID-19 has, significantly impacted children and adolescents, both physically and mentally. If we look at minority youth, they have been disproportionately impacted in lots of ways. Frequently not going to school nearly as much, already having ACEs and decreased socioeconomic opportunities in their families, that then gets exacerbated by the pandemic, especially as we think about job loss, especially in some of those industries like hotel and tourism, some of the service industries that we talked about, restaurants shut down. So we saw a lot of loss and loss of economic opportunity early in COVID, which negatively impacted the families. Depression and anxiety has been noted with almost every pandemic, whether it's been H1N1, whether it's been Ebola, whether it's been other flu epidemics. But again, those minority communities were 2.5 times more likely to be hospitalized or die. As the Delta variant has increased, so has the fear in minority communities. I was recently talking to a friend who happened to be Caucasian, and we were, really kind of, in some ways, laughing and lamenting the difference in responses. So as I was on the side of town that happens to be predominantly Caucasian, what we're seeing is folks in stores without masks, and life had kind of gotten back to normal. On the minority side of town, what we began to see were people actually driving along in cars wearing masks, and they were in the car by themselves or walking on the streets wearing masks. And so there really became a very different processing and fear related to the Delta variant, especially in minority communities. As the pandemic has overlapped with the racial justice movement, how will that play out? How will that continue to play out? I think that what's really striking is I'm a person that tends to, attend church on a fairly regular basis. I have not been in a church except for funerals and a couple of specific services over the course of the past year and a half. Whereas if I talk to many other groups and other friends, they are open. Churches are open, other areas are open, and so there's been much more interactive kind of work, whereas I've seen in minority communities, not nearly as much. And we've also now seen more of a movement from the adult population to the child population as well. As we look at the number of cases, the number of hospitalizations, the number of deaths, they were all continuing to rise. Thankfully, I think that we may be at a turning point where we may see some of these numbers maybe drop and stay down. However, if you look at the data over the past several weeks, there is some suggestion that COVID numbers may actually trend up. But I think that is still one of those things that we're waiting to see. The psychological challenges, we talked earlier about the move with criminal domestic violence and seeing our numbers increasing there. The family psychological distress, again, job loss, family stresses, kids at home, etc. We find ourselves in a very difficult spot. The increased demand for mental health services at the same time that we see a drop in mental health providers, and then the overall level of distress. The thing that I've been really struck by during COVID is the response, not only from myself, but from many of my colleagues and friends, the level of distress that we're feeling as folks who are middle class to upper middle class folks who aren't worried about many of the day-to-day stressors that others are worried about, but still the overall just feeling of yuckiness, stress, and all the things that are going on that make us feel down each and every day. The educational challenges, we know that as the pandemic has continued, we've seen minority youth fall 3 to 5 months behind. Those numbers are actually probably greater based upon some of the newer data, but Caucasian students falling 1 to 3 months behind. I worry that in many school districts, we're actually seeing challenges so that we may not be measuring some of these things as closely as we would have in the past. We're seeing more health disparities that are happening with kids, especially in multi-generational homes. The social isolation has, of course, become extremely problematic, and we're looking at ways of being able to manage that, including the use of technology. Institutionalization has become really problematic. So as we have moved through COVID, there's been a push to really begin to move more kids out of institutions. And while generally that's a really good thing, if you look at lots of organizations, it may be the only place where kids begin to actually get mental health services. So for example, as we think about social welfare agencies, as we think about juvenile justice and courts, frequently those are the folks that are referring kids for mental health care. So while those systems may have negative associations at times, there's also the positive association of let's get more kids into treatment. And then, of course, some of these other issues, which we've already talked about. So I will actually stop there. And thank you so much for allowing me to kind of engage with you. And I'll open it up for any questions that folks might have.
Thank you for that, Dr. Rogers. We did have some folks talking when you were talking about type 2 trauma, or like type 1, type 2 traumas, and one of the questions was, would you say the type 2 trauma increases your chances of being involved in other symptoms? Maybe, Tanya, if you put something a little bit more so I understand more what you're saying with that question, but if you talk a bit more about that type 1 versus type 2 trauma piece, and I guess what that can trigger for folks.
Sure. So if we look at the early work, so psychiatrist Lenore Terr looked at a kidnapping that happened with a group of kids in California. I think it was back in the 70s, and Chowchilla. And so what we find from that particular incident is if you look at those kids who had that as their single event, what we found is that most kids, even though it was fairly horrific, stole the bus ended up getting buried, kids were kind of there, it took a while to find the kids. Most of the children with those type 2 traumas, type 1 traumas, I'm sorry, actually turned out relatively well. There was a subset that struggled with some symptoms, but as long as you have pre-morbid coping skills and you have adequate social supports, many of us are able to survive type 1 traumas okay. The type 2 traumas create kind of a couple of issues. One is to get into the type 2 trauma, especially within the family, it kind of suggests that there were probably pre-existing conditions to begin with. In other words, if you were being physically or sexually abused in the family, you probably had adults with some degree of emotional challenge, we'll call it, prior to that event occurring. And now you've then got this ongoing event that may occur over months or years where people are not able to protect you. And so as I described from the patient that I saw yesterday, you now feel like I'm kind of on my own to be able to deal with this. And think about how the adolescent mind or the child mind frequently works. Rather than being able to rationalize it, it's going to be, it's my fault. I put myself in this situation. I should have done more. And so now we're moving into self-accusatory kinds of mode that then gets into the makings for depression, anxiety, and other symptoms that are there. And as it goes on, the child is not able to then reach out to other positive individuals because you're going to start seeing things through a very negative lens and becoming distrustful of others. And so you end up with family issues that turn into individual issues that then turn into help-seeking issues because they're not able to fully engage. That then becomes a problem over an extended period of time.
And I think she typed in a little bit more, and I think actually leads back to one of the things that you were talking about earlier. So her question, sort of expanding on that, was, would the frequency, intensity, timing of trauma greatly impact we who grow up in a hard place? Like are they hardwired differently? I think you talked, when you're talking a little bit about the lack or absence of safe people and safe places shapes us. Like you're talking about becoming unpoor or essentially resetting your mindset and how you see yourself. Like, would that be even more difficult, I guess?
Yeah, thank you. That makes a lot of sense. And it gets into an interesting developmental question. So if we think about childhood development, what we begin to see is when a child is born, you've got millions and millions of nerve cells in your brain. By about 6 years of age, those get pared down. And they get pared down in a way that really is very, very focused. That pairing really takes away the ones we aren't using, but keeps the ones that we're using. So for example, for the kid that learned to play the piano as a very, very young child, it's kind of stuck in their brain because it's hardwired in at that point. For kids who were read to a lot as a kid, a lot of that gets hardwired in your brain. But for kids who experience trauma, that can also get hardwired in your brain. And we know that even traumas that happen as young as 2 years old can get hardwired, because even though the child can't talk about it, the brain remembers, and it gets wired into one's brain, even pre-verbal stuff. Now, the brain is going to continue to develop until the late 20s. And so those first 5 or 6 years are going to be intense. But things that happen during especially school age kids and even into adolescence are going to start to get hardwired as well. Because as we think about moving from developmental stage to developmental stage, we think about things like trust versus mistrust, autonomy versus shame and doubt. Those stages that we kind of learn about in child development, if we don't and aren't able to kind of work through each of those, we find ourselves not being able to have the skills that we need to be able to process. And so, yes, it can make trying to work with a 21 or a 22-year-old or a 50-year-old difficult, especially if there's not reparative work that's been done or is able to be done. So the quicker you can actually begin working with someone, the better. But even if it's not until much later, there's still ways of mitigating the effects of some of those early childhood experiences that were very negative and really impacted us in a negative way.
Another question, discuss a bit more about maternal maternal depression versus caregiver depression and impact related to school readiness and long-term, specifically thinking about Head Start children. So those kids, Head Start, early Head Start, before they get to school, going into Head Start programs.
Absolutely. So if we think about some of the early stages, one of the things that a child gets from a parent, usually, frequently a mother, sometimes it's aunt, uncle, grandfather, grandmother, grandfather, etc., is the ability to read facial expressions. So somebody looking at the child, making eye contact, smiling, social smile back, that's how you learn your initial socialization. If you look at a child that's usually about 3 months, you can begin to see that fine dance kind of beginning to play. Mom smiles at child begins to chuckle, scratching the child's tummy, rubbing the back. You get used to this touch, this nurturance that's there. You then begin to move into what's called rapprochement. And it's this thing where the kid is there, they feel safe with the parent, and they're able to go out and explore the environment and come back. And they always know there's going to be a home base, and they will usually go further and further away. At first, I'm going to be, a few feet on the floor. Then I'm going to go across a room. And that social development is what a child really needs. So what happens in maternal depression? If you've got a mom who's depressed, the social smile is not going to be there nearly as much. The eye contact is not going to be there nearly as much. And so that fine dance that we were talking about doesn't begin to occur. And so the child grows up with not having those cues. So how do we know what's good and what's bad? So, for example, I'm doing this presentation today. If we were in real life, I would be able to look out in the audience and I would be able to see the folks that are kind of sleeping. I would be able to see the folks who are kind of nodding their heads of like, yeah, I'm understanding what you're saying. I'm going to see the people who are giving me eye contact, and I'm totally reading cues all the time. Kids read cues all the time. And if you have a mom who's not able to give those cues, the kid's going to grow up in this place of what does the world really mean? And I haven't learned to kind of read the audience and what's happening as much. And so I'm now going to be in a space where I become socially blunted in some ways because I'm not able to distinguish what's happy and what's not, because I'm not able to look at my behaviors and get a response.
Yeah, so different type of not being school ready if a child's not been given those cues. Another comment, I love the emphasis on support systems. Life is difficult for everyone to maneuver through, and children still need adults who will help them. Sometimes programs focus so much on the negative issues and don't maximize the survival strengths that many of our clients possess. Messages from trusted voices can go a long way to build resistance to negative impacts. So your piece about, I guess, interdependence as opposed to dependence or independence, that interdependence on the systems that support folks.
Absolutely. And you know, the other thing I talked a little bit about was the impact of parents. I frequently, over time, I've become very focused on what's frequently described as the angry mom. And part of what I think helped me to develop in life was the take no prisoner attitude of my mother. I was a bad kid. I got suspended from school twice before the 6th grade. I was always in trouble about something, but it was really more a curiosity than anything else. I think the thing that would have happened with me, and I actually saw some of it occurring, is the school started kind of labeling me as the bad kid. But my mother was the person who was frequently at school a lot and mitigated a lot of that stuff from occurring. She was the person who was actually identified by people as the angry parent. But what it really was is it was much more of a mama bear kind of, I'm going to protect my cub kind of response. Which, had I not had that, I frequently wonder where I would be at this point in time. And so when I see those moms coming in the office now, part of what I find myself doing is really helping them figure out how to take that energy and use it in a way that people can actually understand, which is something that oftentimes has never really occurred because the behaviors have always been seen as negative. And so people were trying to extinguish them rather than focus them. And so I think that that's one of the things that if we're better able to do, we can actually create a different level of support and engagement for our kids than we currently do.
She wasn't the angry mom. She was the advocate mom. she was your cheerleader.
I know she was the advocate mom, but other people probably didn't see it that way.
Right. Yes, someone's taken socially blunted. They're going to be using that. Enjoyed the information, helpful to me working with my families. This comment from Kimberly: depression is so real within a lot of households. It goes unnoticed or discussed. Ariel says she's very much the advocate mom. And can you talk a little bit more about that? Because I think I've had this conversation with a friend recently that people, especially younger people, sometimes overuse the word depression. Like, it is a real mental health concern, but we say all the time, oh, I'm so depressed, but it's like, are you really depressed, or are you just having a sad day? But actual depression as an illness, how that can affect a person's life and children's lives and families' lives. You talked a little bit about that, but maybe talk a bit about the overuse of depression and understanding that depression is not something so light and easy that people sort of seem to take it as sometimes, by like using the word so much, not really recognizing the seriousness of depression.
Major depressive disorder we know is going to be different from what I'm going to call mild to moderate depression. So if we think of major depressive disorder, we think about suicidal ideation. We think about not being able to function, get things done, focus, your concentration's off, it's kind of this ongoing, pervasive thing that's there. And I think that is incredibly important to appreciate and know that if somebody is experiencing serious depressive symptoms, we really need to think about treatment, getting them involved in treatment, and the impact that can have on the family. That being said, I also think there's something to be said about what we would think about as mild to moderate. Because if we look at, and I will be curious about the research that will, come out over the next few years. If we look at what we've kind of thought about as kind of mild to moderate depressive kind of things that may be subclinical, I think we're also seeing a negative effect that's happening as well. Case in point, I saw a young lady yesterday who was 12. Her mother has a history of anxiety. It's low-level anxiety, but it's always been there. She also has a history of depressive symptoms. Again, probably subclinical. You probably wouldn't diagnose her with depression. But we have now layered COVID on top of a subclinical anxiety and depression, which then creates, how do I process through the stressors that are happening? So her daughter was trying to figure out, I've got 2 other siblings in the house that are younger. I'm feeling more isolated. I'm feeling more stressed. I don't know what to do. And so she's having suicidal ideation at this point in time and actually has a major depressive disorder. But mom's also struggling with, what do I do with this? Because I can't, and I haven't been able to kind of see the symptoms that are there. And so it led into a really interesting conversation of what became kind of normalized in mom's mind of everybody's stressed, everybody's anxious, everybody's depressed. And so what I'm seeing in my child, I'm actually shocked when the teacher calls me and says, I think she needs to see somebody soon because I'm concerned about her. But mom wasn't able to pick it up as well because of her own stuff. And so I think that beginning to kind of grade out what is kind of a real depressive disorder versus what's kind of this minor stuff we used to see has kind of become problematic during the pandemic because it's not as easily readable just because of the level of stress that's been superimposed on top of it.
Sort of like the waters are so muddied, it's hard to see.
It's very hard to see.
Gotcha. Wow. Yeah, Cassandra, I feel that this pandemic has created major depression for many people.
And it really has.
Yeah.
I look at even, I mean, I'm a psychiatrist. I've been practicing for 30 years or so, but I even think about the self-regulatory stuff I have to do with myself sometimes, and to really capture, am I feeling this way because I'm depressed or sad? Am I feeling this way because of something that's happened? Or is it just the cumulative effect of everything that's gone on? And most of the time when I ask myself, it's the cumulative effect of everything that's gone on. But I'm having to constantly think through, how do you keep those stressors at bay in all of our lives?
Yeah, definitely. Definitely. Any other questions? Yeah, many have lost loved ones. Yes, COVID's greatly shaped our lens. Any other questions or comments for Dr. Rogers while we have him, who, as he said, started at the beginning of the pandemic as the new state director for the Department of Mental Health. Yes, the cost of mental health is real. Yes, definitely.
But Nafi, I just want to thank you for letting me come and hang out with you guys for today. I really appreciate it. Thanks to the audience. I know that I haven't been able to see you guys' faces and eyes and stuff, but I feel the love. through Zoom. So thank you so much. I really appreciate it.
Thank you so much, Dr. Rogers, for taking time out to join us today and sharing this information.